we move on to our next session, which is the state of the art lectures. And to chair this session, I invite Dr. Sanjeev Saigal. Dr. Saigal is Principal Director of Hepatology at Max Healthcare Saket in Delhi. And I also invite Dr. S. Sudhindran, who's the Chief Transplant Surgeon at Amrita Institute of Medical Sciences, Kochi. And he's also the President of the Liver Transplant Society of India for this year. For the first talk, we have Professor Anil Dhawan. Dr. Dhawan needs no introduction to this audience. He's the director and head of pediatric hepatology and transplantation at King's College Hospital, London. And he will be talking on liver transplantation for Wilson's disease. Professor Dhawan, please.
Thank you, the chairs. And before talk about Wilson disease, I think I want to make it a bit of a more of a medical and surgical talk and give for the young clinicians and the surgeons the background of how the Wilson's disease came into discussion and where we are over the last 50 years now since it was discovered, or more than 50 years. So the first discussion or description of Wilson disease that came was in, if you can see this paper, which appeared from Kinnear Wilson. He used to work between King's College Hospital and Queen Square University, Queen Square Institute of Neurology. And that was in 1930s, 1931, precisely. Since that time, King's College has evolved, and that was the time where he worked the background of the hospital. This is a new part. And there's a Kinnear Wilson ward named after him. So that's a neurology ward. The debate continues whether it's a Wilson disease or a Wilson's disease. And what you have written is Wilson's disease. That's certainly not the case. And the argument is Wilson himself didn't suffer from this disease. Hence, it shouldn't be called Wilson's disease. There is something in, grammar, if you want to put it that way. So people keep using the term interchangingly, and I may have some slide which may show one or the other. Coming to the topic of liver transplantation in Wilson disease, the first case report of so-called Wilson disease is described by none other than Professor Tom Storgel. And his case report came in 1971. That time the child was 11 years old. But if you read more details of this report, and people who deal with Wilson disease, they will start really querying, did this child really had Wilson disease? But nonetheless, whatever the availability of tests that time was, there was no genetics. So he was diagnosed, considered as Wilson disease, first patient to be transplanted. And he very nicely described in quite details his outcome. And he went on looking at his copper. And if you see here, even just after a year after transplant, they gave him 3 days of penicillamine and they showed the copper was very high. The people who deal with cholestatic disorder, they will say that any cholestatic disorder will raise your copper. It doesn't have to be Wilson disease. But this is the first reported case of Wilson disease who had a liver transplant in literature. So whatever we like to contribute, or whatever we like to debate, that is the case that remains. I think what we want to discuss here is really, I would like to request you to avoid liver transplant in Wilson disease. And that's a ridiculous statement to be made to a transplant society, people who are, majority of you are dealing with transplantation. But my pleading to you is that try not to do transplant for Wilson disease when it's not required. And he will say, you are making a ridiculous statement when it's not required. We don't do it, but I will tell you when it gets done, when it's not required. So liver disease in Wilson disease had two presentations. One is acute presentation, which is again of two types. That is liver failure with encephalopathy. Encephalopathy is extremely, extremely, extremely important. Please remember it. And acute liver dysfunction, or acute on chronic liver dysfunctions, as some of us like to call it. And then there is a chronic liver dysfunction on treatment. In other words, you call it decompensated cirrhosis. If a patient with Wilson disease has ascites, portal hypertension, and that is a slightly different category, we'll come to that. Just to put in a context, in 1,300 plus children who had a liver transplant, 23% of those people, children, required liver transplant metabolic disorders. So for simplicity, copper is a monogenic disorder based in liver. Primarily ATP7B is in liver. It's in other places also, but predominantly liver. Out of this 23%, if you look into this 23%, I think liver, historically, if you put all the data together, Wilson disease comes as a second single common cause for liver transplantation in our population after alpha-1. Alpha-1 is the most common metabolic disorder in Caucasian population. So hence liver transplantation for Wilson is done. It's important. When it's required, it's life-saving. So the question is, when you have a child presenting to you or an adult presenting with acute presentation, who needs a liver transplant and who can avoid a liver transplant? So to differentiate now the patients who are not going to do well, this is a bit of a history. So the so-called fulminant presentation was given to Wilson disease because its outcome used to be disastrous. And it's a French terminology that was used. So they defined it as severe liver failure, severe failure of the synthetic function, associated with encephalopathy, associated with variable degree of hemolysis and renal failure. Very high mortality, 100%. Hence, the consensus has been to go on with liver transplant. But how do you differentiate this time when the patient has come to you, very short history, few days, and you haven't got time to differentiate between indeterminate acute liver failure or idiopathic liver failure or non-A to CV, but we call it, between Wilson disease. So there are some criteria people come up with, and this was one of the papers, which was again in about 1983, so early days. What they described was fulminant Wilson had a higher copper level in serum, urine, and liver, goes without saying. But they had interestingly less pronounced elevation of AST for that matter, higher concentration of total bilirubin and lower hemoglobin levels. So in other words, they had anemia disproportionate to the disease, and the children or adults with the other etiology of liver failure did not have anemia, did not have that high concentration of bilirubin, and that's because of the associated hemolysis, and they have a less pronounced elevation of liver enzymes. So if you get a patient who have lowish ALT, AST, and very low alpha-lactam phosphatase, then very likely you are dealing with a patient of Wilson disease in liver failure. Then somebody brought in alkaline phosphatase total bilirubin ratio, AST to ALT ratio. But what people are trying to say is which patient with Wilson disease are going to be benefited by liver transplantation. So they continued, and then they reviewed data. This is King's College paper in 1992, 21 patients against 193. And I think this stays. Alkaline phosphatase to bilirubin ratio appears to be very sensitive. Now, interesting thing is what we have to see here is the 21 cases of fulminant Wilson disease compared to 193 idiopathic liver failure. So their neurological status at that time was not different, means they were all encephalopathic. But in Wilson disease patient, there was no survival without transplantation. But in idiopathic group, 143 out of 200, roughly, so say 20% survive. So point here I'm trying to make is if you get a Wilson disease with encephalopathy, but not grade 1, when you were not sure, grade 3 or 4, then they need an urgent transplantation. In this, they have all kind of treatment, plasmapheresis including. Now, Wilson disease is a genetic condition. You're born with it. Your genetic defect of copper metabolism with you from day 1 of life. Some present at the age of 5, some present at the age of 15, some present at the age of 50. So why there is a variation? So I think there are so many factors that we don't have time to discuss, but there is always, most of the time, there is an incident, there is a factor that precipitates their presentation. In hepatitis E infection intercurrent, influenza A, adenovirus, what we have seen, and hormonal changes when the children are becoming adolescent. So particularly the female in their teenage group, years are more predisposed to it. And there is an animal model that differentiates that if you take the ovaries and the testicles out of the rats and give them testosterone with or without, the testosterone appear to have a positive or survival benefit. So in females with high estrogen, that appears to be not a protective factor. What do you do in this setting? So you will have a patient before you transplant. So you need to treat them as acute liver failure, remove copper, which makes a lot of common sense, and you stabilize the patient maybe. People have used antioxidant with variable results and transplantation. That's the main talk is today. Copper removal, there is a great rationale behind it, but I wish copper was the only problem. And I think that's where the problem is. Some people get obsessed with filtering copper and saying, oh, we are winning now because copper is coming down, but copper has done its job and moved away. What has happened is extreme damage to the liver that happened, like a paracetamol patient. The injury has happened and gone. That's same as paracetamol. Copper has done it and moved away in that acute phase. But then you are managing a syndrome of acute liver failure. Hence, the treatment will not be very different than what you do, what you are comfortable with any other liver failure patient. So there is a data on plasmapheresis. People recommend, and some people believe in it, and they believe in it so much that sometimes either they will miss the patient or they will overdo it who doesn't even need it. So that's the word of caution. Plasmapheresis, hemofiltration, single pass albumin dialysis, MARS, everything will work. Now, this is something I want to take you back about 20 years. I think this is the seminal paper that has really changed our thinking about Wilson disease management, even when they're severe hepatic insufficiency. Means they're coming to you on the face of it as if they will need a liver transplant. And let's see what happens in these 17 patients. So what is here is earlier on, 1969, they died, no transplantation. But Wilson disease, when the penicillamine was administered to these patients from 1989 onwards, what you find is that most of these patients survived, or all of these patients survived, despite being seen as a very severe decompensated liver disease. So hence, message to you is, if there is no encephalopathy, look at this line. If there is no encephalopathy, if you give them penicillamine, irrespective of liver failure, they survive. So that is an important point I want to make, and I will take it further with some data. So we looked at this 57 patients, and we go backward because there was an initial paper from King's College Hospital which got published as Nazar score predicting survival or mortality of acute presentation of Wilson disease patients who could survive with penicillamine. So that was a predominantly adult population. So we revisited this and added on more patients, and with the modern and more sophisticated statistical packages that we have, we came up with a slightly different system. And now it makes sense in hindsight because we are dealing with acute and chronic liver dysfunction here. It's not as a normal liver that went into decompensation. Hence, systemic infiltrate response markers of synthetic function and detoxification were relevant. So what I want to say here is that for people who think every person with Wilson disease should have a liver transplant, the answer is no. It may take several years for the liver function test to become normal, but we only lost 2 children in follow-up who stopped taking their medication. Other than that, anybody who got into penicillamine and survived first few weeks did not die after in the follow-up. So question here is, now you will say, I was saying to you that acute liver failure in Wilson is no different than others, but there is a difference because copper is relevant, and it's like an autoimmune liver disease where there is a treatment for once you survive initial part of it. So should we use standard criteria for liver transplant for Wilson disease? You can use a MELD score for that matter, or King's College Hospital criteria for acute liver failure, or other criteria, or that you have your own criteria. And the answer is maybe not, because we have a reasonable number of patients now where we can do some statistical analysis. Can we come up with a different kind of scoring system? So we and others have looked at it, and this is a original paper which was Nazar from 1986. And that time they looked at 3 total serum bilirubin, AST, and INR, and their variable numbers. And what they found is there are several of these patients were outliers in both. Those who survived with more than 7 and those who died below more than 7 or 7. So positive predictive value of this test, when we revisited it, was only 8.7, or sorry, likelihood ratio. We revisited it with a different number, increased the numbers, and we found that criteria, on the univariate analysis and subsequently multivariate analysis, white cell count and albumin came up another markers which were not there before. And that's maybe indirectly a SIRS markers, what we are looking at indirectly. So looking at this data, and when we created this numbers under everything, all the data is created because of receiver operating curves. And what we found is when we had a cutoff 11 or plus, the likelihood ratio improved to 22.8 from 7. So I'm not saying that is 100%, but you still have in the raw data, there are 2 patients who are still outliers and third one hasn't made its mind. So there is still work to do, and we have revisited the score. The paper is under publication, but what comes out is the score of 11 still sticks to that in even our 15 years of prospective revalidation of the score. It was further revalidated by a group in Czech Republic who had adult center predominantly, and they compared it with MELD, with Wilson score, Wilson index, they called it, and they found that this fared well in their hands compared through MELD scoring system. What we all talk about when we talk about liver transplantation is once we have decided who needs a transplant. So just to recap, if you have an encephalopathic patient grade 3-4 with Wilson disease, I think the best option for that patient is liver transplantation. Other than that, I think you can do other things if you want to try all the modalities and chelation therapy. Now, once you have done a transplant, what are the outcomes? So I just looked this paper, which compares outcome adult and children. And what I want to bring to you and challenge my adult colleagues in the audience today, what it shows here is if you look at critically, in young children, fulminant liver failure or acute liver failure as a presentation has been as the indication for transplant. But as you get older, the chronic liver disease becomes an indication. And I will challenge why. Are the patients not taking the treatment, or our threshold for transplanting is low? And that is the question I have, because I will not say that tacrolimus is any kinder to mankind than penicillamine. So having your own liver is always beneficial. So similarly, look at the survivals. I think what we can say is if you were to counseling a patient with Wilson disease who needs a transplant, the outcome as a children are 100% survival for a chronic liver disease, 87% for fulminant liver failure patients. While in adults, compared to other outcomes, I think they may be better than your alcoholics and hepatitis C patients. They are in excess of 90%. So to conclude, transplantation outcomes for Wilson disease, both for acute and chronic liver disease, when indicated, when done, are very good. And this is just to say, comparison of the acute and chronics. Chronic people do better than acute. The question comes, the acute liver failure when you are having living related transplantation, and part of the world when we are talking about is living donor transplantation is the mainstay, and single sentence is the living donor and the donation, even if it's a heterozygous donor, it is of no significance. So this is the Japanese experience, which shows, and they have done extensive data showing that, the donor didn't come to harm and the recipient showed great outcome. Followed by the Chinese group, and there I'm sure the Koreans and Indian data is also there, which shows that both in acute and chronic liver failure patients, when the living donor transplant from the family members were given, they had a good outcome. The interesting question comes, if you have a neurological Wilson, what will happen with liver transplantation? And answer to this day today is not very clear. There are case reports from the same group, 95, 2000, 2001, saying starting with no neurological improvement, then subsequently they report good motor and moderate cognitive improvement, and then there is a full recovery after transplantation. So what they are alluding to is that people with neurological disorder should get benefit. Now, if you have a liver disease and a neurological disease, it may be easier to make a decision. So in this outcome of 41 patients who have liver and neurological disease, 35 were combined. And in 6 patients, they were deteriorating neurological function. So what they reported is in 12 patients, there was a complete resolution of neurological symptoms, which is very good for somebody who suffers from neurological problem. Remarkable improvement in 20, and no change in worsening in 6. So The primary patients who had a primary neurological illness, I think they did well. But there is a problem with the recent data that I come from Paris. And the Paris data is very good because it's prospectively done as a registry study. And endpoint is looking at predominantly neurological illness patients. And they have their caution is, they've stopped the program at the moment. The caution is that those who have a severe motor neurological disability at the time of transplantation don't tend to do well because of increased intensive care mortality. They suffer more pulmonary complications after ventilation. So there, it's a slightly a problem, but the patients who were mobile, they did very well. This is a data which shows that this is a group from, it's a group from Italian group. And if you look at here is that before liver transplant, 11 out of 16 has a variable degree of neurological abnormalities, while 1 to 9 months after transplant, I think 9 months after transplant, they have no neurological abnormality left, which is a fantastic achievement for this patient. But word of caution to you would be that if you are going to attempt a Wilson disease, a neurological patient of Wilson disease and a liver transplant, I think just do a bit more discussions around and characterize and risk assess your patient before you rush into it. This is a detailed data which shows what improved, what did not improve in these patients. So what you see here is the tremors perseveres, and some people say it's a tacrolimus-induced tremor now. You have to be mindful and careful, but for a patient, tremor is a tremor, whether it's a neurotoxicity of tacrolimus or it's a Wilson disease. So we have to be careful in counseling that some of the abnormalities that you have may persist. Outcomes, as I was saying before, this is our data, which adult and pediatrics together, which published long time back now, about 2003, because these are not many patients we transplant with Wilson disease, hence the data is not that much to present. And this group that we published in about 40 odd adult and pediatrics showed, compared to our adults and pediatric survivals in those days of near 85%, in patient survival, and graft survival was poorer because of poor compliance in some of these patients. We looked at quality of life in this patient, and it did get better. So they're nearly the mean. So hence, we think that it is a valuable, not only life-saving, but does contribute to improvement in quality of life. What I want you to see, what is the future holds. And some of the things come out of human need, desperation, and what circumstances you are in. This is just, by the way, to give you this cartoon. What it shows is that if you have a tree in your garden that's mature, but doesn't give you good quality fruits, then you can prune a branch and get from another tree, and you can have a tree with two types of fruits. In other words, in this case will be some of the liver cells that can process copper and others that cannot process copper. So with that kind of a logic, so this is the Chinese, I think it's a Korean group first, they had done in this auxiliary transplant, and their idea at that time was, because the donor size was small, so they wanted to liver to increase in size, donor liver size, while the native liver was kept, and then do the recipient hepatectomy. The Chinese group since has taken an approach that can this transplanted liver will act as a chelator, which is a great idea. It's a normal biological chelator they're using. And when later on, whether their native liver will get decoppered, and then the patient will go back to maybe a transplant only rather than Wilson and transplant. So when I saw this patient when I was in Shanghai, I was very intrigued, and I'm still awaiting the follow-up from Dr. Zhu's group in Shanghai. What would be an ideal treatment for a single gene defect metabolic disorder? I think what we are doing at the moment is, you guys are doing a great job, the transplant surgeons. You are doing a crude gene therapy. You are giving such a large dose of a gene corrected cells that transplant, or you can call it corrected cells, but that comes with its own complications, as we know. So future for a single based gene defects, liver based gene defect would be gene therapy. While we are going through this, there are CRISPR-Cas technologies, and whether we are going through a phase at the moment where a large group will get a complete donor hepatectomy, a smaller experimental group can get benefit by an auxiliary transplant, a small group will get benefit from hepatocyte with ex vivo gene therapy, or just to tide them over through the acute decompensation phase when they come, and then we can manage them with penicillamine, trientine, or tetrathiomolybdate. And ultimately, the gene therapy trials, whether gene therapy will correct the ATPase7B's defect in these patients, I think that should be the ultimate goal. When will it happen? The trials are, animal studies are very convincing, but humans are not animals. That's what you all know. Hence, we don't know whether we will behave like animals, and I hope we don't behave like animals literally. But I would like to say that for gene therapy, we should behave like animals. When they get corrected, they behave and they correct their disorders. But so far, it has not been successful that much. But the future, we shouldn't dismiss it. And one day, maybe for every single monogenic gene defect, treatment would be gene therapy. With that, I thank you very much for listening, and I will take some questions.
Thank you, Professor Dhawan. It's a fantastic lecture. It's always a delight listening to you and interacting with you. You have given a very good message, and you have really, stressed on the thought that Wilson's is a medical disease, and as far as possible, we should treat it and avoid, like transplant, which is the it's an autosomal recessive, which we know as an inheritance, and living donor transplants are being done. We published about 18 patients, a series published from India, 2018. Just one thought once again, you did mention, but I just want to ask you once again, when you're selecting donors for a Wilson's disease in a living donor setting, I mean, is there any concern from selection of donors, parents, brothers, regarding the disease pattern in the recipient later on?
Yeah, so obviously, it's a autosomal recessive condition, and family members most of the time are carriers of this condition. The question is, can you use a heterozygous Wilson donor? Our experience is negligible. We had 2 or 3 from Middle East who came to us, but the big centers like from Kyoto and from Korea and China have experience, and they have evaluated a donor in great lengths. So Tokyo group went on doing liver biopsies on the patients with heterozygous, looking for abnormalities. But their outcome now was so good that they have stopped doing it. So the message is, heterozygous Wilson disease donor is not a contraindication to transplant. As far as the donor health goes, I think the rest of the precautions that you take, that stays for any other patient, I would say.
Right. Thank you. I think that's very useful message. And how comfortable are you treating with, in a very sick patient, giving deep penicillamine, and patient is sick, and you have to give them this therapy. So what's the level of comfort in a sick child which you're treating?
So level of comfort is that what can happen? That's the question. If you give penicillamine, obviously we won't give penicillamine if somebody is anuric. Okay, that wouldn't make sense. If somebody is passing urine, then we will give it, and we do give it. But only anuric patient will take me away from not giving it.
Professor Dhawan, we have a question in the chat box. How common is recurrent conjunctivitis and post-liver transplant for Wilson's patients?
Very good question. I have not seen it, but I may have ignored it and said, oh, go and see your GP. But next time I will keep it in mind. But I have not seen it as a major problem. No.
And this is Dr. Soma Shekhar who asks, what is the rationale for including white cell count in Wilson's index?
So, Soma Shekhar, the rationale, we didn't think it will come, but it was when we do a univariate analysis, we put every single parameter. Then we did a multivariate analysis. So that's why the statistical package brought it out. And we think now it's like acute on chronic liver failure CLF patient, what you're looking at SIRS response. It may be a surrogate marker for that. It does come in other acute liver failure also, acute on chronic liver failure particularly. So I think it may be a marker of overall sickness of the patient, but not directly anything to do with Wilson disease.
I think one last question. This is from Dr. Vishwanathan, who says, what would you advise Dr. Dhawan for children presenting primarily as neurological Wilson's?
Well, they should be treated medically first. And if the medical treatment fails, then it's unlikely to fail because it succeeds. But if the medical treatment fails, then you're in experimental territory. then I think any decision you make shouldn't be done by one person. You should take help from people who had experience with neurological patient, difficult ones, and also depends on the neurological severity. If they're crippled, if they are bedridden, contractures, they won't do well after transplant. But if they are mobile and you think your medical chelation is not working, I can't see why not. But if it is a reason, then transplantation may be an option, and auxiliary may be a good option that times. You don't risk the patient completely. But I also like to tell you that tetrathiomolybdate, which has just come in, has completed phase 2 trials and clinical phase 1/3 trial in adults in a small group, had shown a very good outcome. So there are more drugs coming in terms of for treatment of, and that may make more sense to try a newer chelating agents rather than going for a transplantation.
Wonderful talk, Professor Dhawan. Neeraj,
Yeah,
you would
thank
like to
you.
move on?
Thank you, Professor Dhawan, for the wonderful talk.